Hello, my name is Major Nufukakai Bashurin, and today I will be presenting to you the case of a patient that I refer to as RF. This encounter was completed as a voluntary virtual visit on December 9th, 2025. At the start of the appointment, the patient confirmed that he was alone in his personal residence in a safe environment and without access to weapons. Physical address and phone number was confirmed, consent was obtained, and the limits of confidentiality were reviewed. RF is a 21-year-old African American male active duty Air Force E4, currently working as a communications specialist. He is single, he lives alone in the barracks, and self referred for the psychiatric evaluation. When asked why he came in to the appointment, RF stated in his own words, "I have been feeling anxious lately." RF described increasing anxiety that has begun to interfere with his emotional well being. He denied any known long-standing psychiatric conditions that could be contributing to these current symptoms. So no specific predispositioning factors were identified at the time of this visit. Patient reported that his symptoms were precipitated by a recent performance-related stressor. Specifically, he received a 95% on an exam at school. Although this may seem like a strong, excellent score, patient RF interpreted this as a failure because he typically earns a perfect score of 100%. Since this experience, a patient has noticed an increase in anxiety related to performance at school and also at work. Patient symptoms have been perpetuated by this ongoing drive for perfectionism and with additional occupational stress. Patient places very high expectations on himself and tends to be self critical when he does not meet those expectations, which continues to fuel his anxiety. Despite all this, RF demonstrates several protective factors, which includes he sought care voluntarily, he maintains a consistent exercise routine. He denies any substance use. He has a strong support system, which he named as his mother, his family, and his supervisor. He also attends church every Sunday and shows good insight into the need for him to seek help. From a mood perspective, RF endorsed anxiety but denied depressive symptoms. He reported sleeping approximately 7 hours per night, denied nighttime awakenings, and wakes up feeling rested. He denied changes in interest, energy, appetite, or concentration. He denied symptoms of mania, including decreased need for sleep, racing thoughts, impulsivity, grandiosity, or increased goal directed activity. Patient denied trauma related symptoms such as intrusive memories, avoidance, or hypervigilance. However, during the assessment of psychotic symptoms, RF described experiencing what he referred to as a force or a presence. He stated that this force wishes him to fail, threatens to take over his body at times, and at other times tells him to take pills and end it all. And all this happens when he does not perform to his own expectations. Patient denied hearing voices or seeing things that others do not, and clarifies that this presence is not auditory in nature and has no physical form. RF denied any prior psychiatric diagnosis, outpatient mental health treatment, psychiatric hospitalizations, suicide attempts, or self harm behaviors. He is not currently taking any psychiatric medications. RF denied any significant medical diagnosis, prior surgeries, seizures, or loss of consciousness. He is not taking any medications and has no known allergies. Patient maintains an active lifestyle, runs daily, and participates in water, sports, and activities when the weather permits. RF denied alcohol, tobacco, nicotine, and recreational drug use. He reports taking 1 to 2 caffeine pills a day, and there's no evidence of current or past substance misuse. Family history for RF is unremarkable. He denied known family psychiatric disorders, medical illnesses, or substance use disorders. He denied a family history of suicide. RF described his childhood as fine and reported a good relationship with his mother. He denied having siblings and denied any history of abuse or trauma. He is currently enrolled in online finance courses while serving on active duty. RF lives alone in the barracks and identified his mother, father, and supervisor as his primary support system. He denied financial or legal stressors. His hobbies include working out, running daily, playing rugby, and water sports. He does identify religion as one of his protective factors as he goes to church every Sunday. On examination, RF appeared well nourished, appropriately groomed, and dressed in clothing that is consistent with the weather. He was initially anxious, guarded, and minimally engaged, but became more open as the interview progressed. He was alert and fully oriented to person, place, and time and purpose. Eye contact was good. Speech was within normal limits for rate, rhythm, volume, and clarity. His mood was anxious, um, appropriate, and congruent, and his affect was congruent with his mood. His thought processes were logical, linear, and goal oriented. The content was notable for intrusive experiences involving the presence that threatens to take over his body and urges self harm when performance expectations were not met. Patient acknowledges that acting on these thoughts would be wrong and identify this as a reason that he is seeking help today. There were no abnormal movements. Cognition and memory were intact, and insight and judgment were both assessed as being good. RF denied current suicidal ideation, intent plan, or access to lethal means. Warning signs were not identified during the interview. Risk factors include intrusive thoughts related to self harm and the perception of a threatening internal voice. From a military standpoint, these symptoms could potentially affect the mission if left untreated. Overall, RS presentation appears consistent with anxiety that's related to perfectionism and with intrusive thoughts, and this warrants additional evaluation. Continued assessment is needed. A safety plan was reviewed with the patient, and he was given resources to use in case of any strong urges for self harm. This case really challenged me to carefully assess my risk assessments, even when the patient is denying suicide, particularly when intrusive self thoughts related thoughts are present. It just reinforces the importance of exploring symptoms, insight, and protective factors. This also challenged me to continue to develop a therapeutic relationship with my patient and allow the interview to go where the patient takes it. This time belongs to the patient and should be used as such. This concludes my presentation. Thank you.